Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Fardon. I'm the chair and organizer of Grand Rounds, and it is very nice to be back here in person, looking out at, I was going to say, a sea of real life places. Let's say a small pond, a lochan, as you might say, of people here in the Ganaki Trust Lecture Theatre, and there are our usual number of people on Zoom. So thank you very much for joining in person and sat by a screen. In October, for the last 3, perhaps 4 years, we have devoted one of our Grand Round slots to Black History Month. And we've heard particularly from our students, and I think it's a really inspiring session that we have here in October, because we get the lived experience, we get the experience of people who have come through the systems which I came through 30 years ago, and it's completely different. It's a completely different system, and what has changed? I can tell you, it's very different, completely different from when I was at medical school. I went to Grand Round. There were 200 people in the audience, and they were all one shade. I'll tell you that much, and that was very, very different. And the lecture that the students gave, I think 2 years ago, about decolonizing the curriculum was really, really fascinating, very powerful stuff. And I'm really pleased that Busi Mooka, who is my neighbour down in East Block, has agreed to come and speak today. And we're going to hear from her about Black race in medicine broadly. We have talked frequently about the challenges that we face in terms of the medicine. We talked from straightforward, simple things we do every day, such as pulse oximetry, to things like in our lectures, in the respiratory block. There's a slide about testing if people are cynos by putting your own hand next to their face, and that's fine. That's a white hand that's put down on that slide. And it dawned on me it was only this year, to my shame, that I realized that slide was in my slide deck. And of course, I've moved that slide for this year, and we have a different tack. But that slide was in that slide deck for, I suspect, for probably 15, 20 more years. And also things like spirometry. There's a button to press on the machine that says race, and it's by what do you see in front of you, and what's the basis of that, and is it meaningful, and where does that come from? And of course, over and above all that, is, and I'm sure Busi will go into it, the stigma and whether people are taken seriously, the understanding of the differences, but also the similarities in people when people present to us in medicine more globally. And I'm very pleased that we have 3 students with us who are going to talk about their experiences coming through our medical school, as to what actually, are we making a difference? Are things changing for the better or the worse? And to give us advice about how we make things better. So I will shut up and sit down. If you have questions, then put them into the chat, and obviously there'll be the traditional put your hand into the air later, and we'll ask a question. But I'll hand over to Busi. Thanks very much. Yeah. Spontaneous round of applause in the auditorium.
Very spontaneous. Thank you, everybody. So I'm just going to talk about some of the experiences of being Black. They cannot be the whole of the experience, and of necessity, it's a very, very narrow conversation. It's not talking about me as a woman or any of the other characteristics that I have. It does not negate any other characteristics that exist. So it's just a very specific, very narrow slice that we're talking about. We have a whole list of resources that we will circulate after, because again, the depth and breadth of questions can probably not be answered in this forum. And there is a wealth of literature that you can go and look up afterwards. And there's a couple of really cracking recommendations I got in books and stuff like that we can always chat about at another time. The point of what we're doing is not to make people feel bad. It's to have a conversation that's real. We're acknowledging that there's lots of polarization and unhelpful conversation that happens. If you don't know, that's not a crime. We can have a conversation about what we can do in Tayside to make everybody's life better. Where's the click for next? one way. So we've all seen the reports in the news. This was the BMA report that was quite startling. 76% of doctors who responded had said they'd experienced racism at work. That's a lot of people. We know about some of the stuff that's been online. It's always easy, of course, to pick on other boards, not our own, but these are the boards that have done the work and it's gone into the media. There's also, of course, the opposite thinking that happens in the media that says this is just woke nonsense with lots of policing of language and behavior. So just to acknowledge that there's many, many different aspects and lots of stuff that's being reported online. We're not immune to this. And of course, where there is a problem, there is a pie chart. There are lots of white papers, lots of papers describing, lots of circles and diagrams and tables describing what racism is, what its various layers are, who might be responsible, how you might fix it, and it's always somebody else's problem. But anyway, all to say that there are very elaborate descriptions. Broadly speaking, for our purposes today, we'll talk about some of the interpersonal stuff that happens. We hope that we can move the conversation upstream because the interpersonal seems very easy to fix, but a lot of the upstream things can be fixed we can start to have conversations about fixing them. And then we'll also talk about, specifically in medicine, iatrogenic racism. We know all about realistic medicine and about quality improvement, and we're always talking about shared decision-making. I might talk about some of the problematic aspects of our shared decision-making as relates to the Black race. We always talk about personalized approach to care, reducing harm and reducing unnecessary variation and managing risk better. A lot of our quality improvement initiatives currently do not address the glaring issues that we have with particularly the Black race. There are issues with being brown, and brown is too broad of a category. That is a whole other 5 talks that we could have, but it's not this talk. There are many, many other things we can look at about that. So things like the fact that Black women are 4 times more likely than white women to die, not have harm, but die in pregnancy, things about incarceration, things about deaths from cardiovascular disease, things about organ donation. Those are all some of the symptoms of what is wrong that we need to look at. So some of my experiences, allegedly I've been married to 2 of these Black men. That's a whole other story. So one of these guys, we happened to be at an invitational golf thing with a lot of people who were not Black. And my husband was asked for an autograph as Samuel L. Jackson, which we thought was hilarious for so many reasons. Another time, the lower guy is a singer called Akon, and we got an upgrade, wink, wink, when we were renting a car because the person at the rental was convinced that Selu was in deep cover, and especially celebrities with one name tend to kind of have a proper other name, and of course he's Akon. So we ended up driving this fancy car for the week at no extra cost. So there are funny things to being stereotyped and actually being not easy to differentiate. But he's neither of these guys. I didn't put up his picture because it's going to go on YouTube, and YouTube, everything lives forever. On a more sober note, the day I became a Negro was I was in a lecture. I won't say what kind of a lecture. And it was a really lovely professor who was very, very good. And I respect him and admire him a lot. But he actually did not know that it was an offensive word that he had put in his slides to describe risk factors. He was talking about a disease condition, because if I describe what disease condition, it's easy enough if you know which medical school I went to go back and figure out who it was. But actually was just describing that Negroes are more likely to have this condition. And because I was naive, I went up to the podium and I was just like, that word's not in use anymore. Please do not call me that ever again. In retrospect, I was terrified. I was just like, what did I just do? But he actually honestly did not know. And so actually, I think Some of that should be encouragement to our students that actually, if somebody does something unwittingly, give them the chance by letting them know that that word, you would be surprised what people don't know. And I think it's a very brave thing of Tom to share about the hand, because actually we're currently in a culture that is not forgiving of people saying, actually, oh, my bad, I should not have done that. So part of what we're hoping from this conversation is those kinds of responses where people change what they do. My child also found out that he was the N word and police were involved and all of that. This was in primary school when we had just moved to Scotland. So things like that still do happen and they're not very remote. The other thing that's important is people's names. So one of the reasons I was not a big fan of the campaign My Name is because the authority and the uh, respect that you get as a Black female doctor is not automatic. And often there is a lot of disrespect that comes, and you're automatically called by your first name to show that disrespect. So having a badge that says my name is Busi is not something I want. It adds to the burden of my social interactions. But I wonder how, when that campaign was conceived, who was consulted? So I don't have the social currency to trade with that makes it necessarily always okay for people to call me by my first name. Often it's actually a continuation of their bad behavior towards me. So I think that's a conversation that's worth having a conversation about. It's also interesting when and this happens to a lot of people, not just Black people, this will happen to anybody with an unusual name. When you have said your name and somebody says to you, oh, you mean, and then they tell you their version of your name. That is a power move. I will respond in the way that is required if somebody does that power move, because it's utterly offensive that I would tell you what my name is, and then you would rename me and expect me to accept my new name. And this happens also in medical records, that sometimes we actually do not write the correct spelling of a patient who actually uses our same alphabet as us and just give them a completely different name. It was very good in medical school. I had really good friends who took me around the hidden curriculum. In Ireland, where I trained, people are very roundabout in how they speak. So when they say, we'll go when you're ready, that means let's go now. So or would you like to examine that patient does not mean would you like to examine that patient. The answer no thanks is not acceptable. And I would have learned that the hard way. When they say would you like to examine the patient, they mean examine the patient, please. So that's stuff that has been really helpful socially, that people who speak the social part of that language have helped. This comes to bear when in theatre, people who are trainees are being asked, would you like to, and then they answer no, and then they're perceived to be not that cooperative. So that's stuff that happens in the background, but that probably happens to all people from all places. There are also fees that only really affect people who don't hold the passport of the country that you're in. So I remember going to a place called the Aliens Office, yes it was called that, for registering for my visa every year. The first year, of course, the people from the Aliens Office come to the college. This was in Ireland, it wasn't here. And because it suits that because you're paying higher fees as a foreign student, but thereafter you're in the rain queuing at the crack of dawn in the Aliens Office with a little green book. I remember that. And then for conferences, you pay extra fees because you have to go and get your visas sorted. So that's a barrier to going to conferences. For some rotations, for my SHO, when it was called SHO, you could rotate to the States, to the Mayo Clinic. But I couldn't go because of the passport that I held at the time. So there's all these inadvertent things that happen. And when you're rotating as well as a trainee, you could do a part of your training. So for example, if I wanted to do transplant, I could go anywhere in the world. But because you hold a particular passport, that's actually not true for you. So that means that when you come out, your CV looks quite different from your peers for what is maybe accidental reasons. Career opportunities are different. There's a thing called the credibility gap, and there's a big literature about this, particularly for women, where depending on your demographics, whether people automatically believe you or ask you to state why you're saying what you're saying is different. If you are a Black woman, that is quite low, that credibility. There's all sorts of interesting literature, and you feel free to go down the rabbit warrens of broken rungs and glass ceilings and glass cliffs. And this is not the only demographic that's affected by this. Some interesting stuff about HR and policies. So it's very easy to come up with policies that just result in a box tick. There are ways that people work around meaningful engagement by saying things like this person is not a good fit for the team. When you dig in under that, there's a lot of cultural stuff. So won't go to the pub with us. There's not a lot of fun. Doesn't seem to understand how we work. All those are things that disproportionately affect people of other races. I remember a very nice person who actually I still admire clinically a lot and socially would still be in contact with them. They had gotten a pile of CVs for a job. And what they did was the first half of CVs they wouldn't read were people who didn't qualify in this part of the world. And then the next half was, can I say that name? And then he started reading the CVs. So things like that, that you can't police that, but there are things that people do that just are not right. And they're informal practice and tend to affect minorities more than others. It is worth saying that just because you're white, you're not a racist. This is worth saying in this day and age, especially when it seems like we're vilifying people by color and maybe deifying others by color. There are racist minorities. Turn on your TV and you'll find them. Look at Twitter and you'll find them. So, and sometimes there is diversity and inclusion tokenism of involving people who are minoritized into decision-making or groups so that it appears that there is representation. I think the cultural competency is also an important metric to look at. So that's just some of my background thoughts. So the thing that I'm going to dwell a lot on is race classification in medicine. Race is a subjective, visual definition. It has no biologic correlate. So that's something that we need to pause and think about. There is international variation about what race is, and I have lots of funny stories about my colored South African friends who moved to countries that have never heard of the category colored, and they suddenly had to go into the category black and were very deeply traumatized by being put into the category black. Race classification is unstable over time, so it has not been the same over time, and it is a social category. So it is a pseudoscience thing to say that something is caused by race. So I'll just leave that polemic to sit a little bit there. And this is a nice, it's not a precise graph, not a precise picture, but it does show you that there is more variation within races than there is between races. And there's a lot of literature behind that. So talking about the fact that it's not biological or innate, this picture here shows you, so it's by a South African artist, one of the definitions for race, because race was particularly important in apartheid in South Africa. And what they used to do was, if you were black, you'd be black enough if you could stick a pencil in and it stayed in the hair. So that's what black was, because there's so much variation in between hair and all of that. So this is just a caricature of somebody with lots and lots of pens in their hair. In America, they had other rules to do with how many drops of black you had, and any bit of black was too much black. And they had lots of definitions for how much black you had, depending on whether you had white black parents and then who the parents were and all of that. And any bit, and regardless of what you looked like, if you had a drop of black, you were very black. And it is important to know that there are not these clear definitions, because when we look at our data, particularly how much of it comes from America and is exported to us with the race factors, it is based on this nonsense. So I have a couple of nieces who have a black parent and a white parent, and depending on who has looked at them what way and what way they're wearing their hair, they may have a correction factor applied or not applied in a medical important situation, and that is problematic. So this is going back to the blue lips and black skin. This is an article clipped out of The Guardian. So somebody who called 111, and 111, when you call them, they prioritize according to whether you're blue or not. If you have respiratory complaints, they still do. That is problematic. So this family was alleging that actually the reason this person did not survive their COVID-19 was because they hadn't passed some of the questions, which actually were not that helpful. There are other things in our medical training that talk about whether you're blue, red, yellow, or pink. I say these because actually those are the colors we care about in those assessments. So in clinical examinations, in APGAR scores, that's important because of our obstetric stuff. Cyanosis, Raynaud's disease, I don't know what the colors are for Raynaud's for somebody who's black. Jaundice, we're often looking in the wrong place, and we maybe might miss the sclera. Pallor as well is something that we could do well to describe better. This is an easily downloadable online book called Mind the Gap, which is starting to compile some of the colors of Black people in different conditions. Pulse oximetry is worth talking about. This is quite startling. So we have known for quite a long time, the literature is quite extensive about how poorly pulse oximeters can perform in Black people. And this is purely because of light and how it works. The startling thing is there is CE marks, there are quality marks on these products, and the regulator has not yet issued, I think, a meaningful revision of what these look like. There's a caveat about how doctors might look at the trend or just do a blood gas. I don't want a painful test. I want a pulse oximeter that works, please. And so I think it's really deeply problematic that this is ongoing. And there are, I think, lots of conversations about, so it's a live thing, there are lots of conversations about it, and there are lots of technical ways to try and fix it. But I think it's still deeply problematic that this is not yet fixed. Other things that are problematic, the NICE guidance has an adjustment, and it's the only guidance in the world that does this for hypertension. So if you are Black, you cannot get an ACE or an ARB as first line. The short version of why that is the case is because when Black people were being transported across the transatlantic, there was salt retention advantage. And I'm thinking, I am from Botswana. I have nothing to do with the transport of people across the Atlantic. And when you have looked at different populations outside of America, and even within America, it doesn't make any sense. So all the other international guidance have removed this. There have been several inquiries of NICE asking them, why do you have this? So if you can picture a 40-year-old lady who spends all of her time at work standing and has slightly swollen feet and can't get a calcium channel blocker, that probably means that she's on a thiazide for her early onset hypertension. That's nuts. But that's what our guidance says. And I think really we need to look at that very soberly and think about it, particularly because we know what the outcomes are like. Spirometry, we talked about that a little bit, and a lot of that is based, this is just pure science from the racist fields. Black people have a different structure of pulmonary apparatus, and you expect them to have 10 to 15% lower lung function than white people. It's pure nonsense. And the race factor that you apply is either self-reported or provider-reported. Thankfully, the Global Lung Initiative has actually issued a statement about this, and it is possible to choose to remove the race factor, but that requires, I think, a fair bit of action. So applying this race factor means you're delaying care, there's inadequate care, and there's different industrial compensation, because actually if your lung function's down, sure, isn't that your normal? So that's slightly problematic. And there's a really good book that goes into all of this. That's really interesting. And it's in one of the references, and there's kind of an interview with the author of it, which is quite good. Other things, if you're Black, nobody knows what size your left ventricle should be or what amplitude of ECG you should have, because Black people are muscly and their heart is also more muscly. And God help you for a Black woman, because you must be somewhere in between. So I think those are the conversations that we need to start having about what is the normal, where did that come from, and why do we not know? And why are the edges of our care like this? EGFR is another one. Thankfully, in Tayside, actually, we're well ahead of the curve in this. So there's due to be a change that removes the Black coefficient, which corrected for the fact that Black people would be expected to have a worse kidney function. And so that race correction factor is due to be removed. But actually in Tayside, because we can't collect race for collecting your creatinine, we don't apply the adjustment anyway. So our EGFRs in Tayside are miles ahead. This is a really interesting paper that I saw that was talking about how much more useful things that relate to Blackness are social determinants of health, and that maybe those are the things that are affecting EGFR rather than just that the person is visibly another color. And there's also interesting data about this renal function stuff. So when you look at data from Ghana, from Congo, South Africa, Brazil, so lots and lots of studies where there are other Black people, they have not found the same correlation. the time. In diabetes, you have conversations about risk factors. So Black race is a risk factor for diabetes, and that diabetes in Black people is more brittle. This is dogma that is unproven. And actually in public health, they have a really helpful concept about upstream interventions and downstream interventions. And sometimes the problem is social circumstances, environmental exposure, genetic predisposition, behavioral patterns. And Black is not one thing, and Black is not a reproducible thing. So Black should probably not be in that. It's probably more helpful to include what the actual social determinants of health are that make a difference. For example, affluence makes a huge difference to outcome, as does education. So I think sometimes it's quite lazy thinking. Another interesting one, and this is an evolving one, is body mass index. If you have a day or so and you're really bored, go into the origins of the BMI to blow your mind. It was a guy who was obsessed with the idea of the normal man, and it was man he was looking for. And so what he did was he measured loads and loads of men in Northern European settings in the US, and then plotted it out. And he was an I always get astrologer and astronomer mixed up, but he's an astronomer and he was a mathematician. And so he came up with a number. Eventually, the insurance companies took over the number, and before you knew it, it made it into medicine. And it was always meant to be a group number, and suddenly it has become an individual number without probing. And so then you see the problems with BMI in that now, when you're looking at the criteria, and there was recently an email that you may have got, which was talking about the criteria for bariatric surgery. So the bariatric surgery threshold has changed according to race, because BMI is so problematic, and we know that maybe more people need to be having it, and so maybe we should change the number. And so the number has changed. And the number has always been a little bit different for people who have Asian origin. So there's a whole load of stuff here that actually just needs to be blown up and start again. So this is saying that, I guess, it's much, much easier to look at all of these different things if you have the patience and troll through the numbers, and statisticians and clinicians and epidemiologists can talk about all of these things. The more problematic, difficult thing is AI. AI means all that rubbish data gets into a black box and then appears at your friendly clinic interface, and you just input without thinking all of the patient variables, and then you get the test result out. And a lot of AI you cannot probe, you can't work backwards. So this is really, really problematic. And a lot of it is also that in America, race was a very specific thing with very specific socioeconomic issues that translated to many, many generations. So a lot of what Black means in America is not what it means in other parts of the world. So there's lots of stuff that's interesting about sickle cell. Most of us in medical school learn that sickle cell is more common in Black people, and then we never expect to find it in Mediterranean people or Indian people. It's actually more linked to geography and malaria prevalence than necessarily to race on its own. There's lots of prognostic scores that include being Black. FRAX is a whole 5 lectures that we could have on that. So it's just to say, AI is the next thing that concerns me, because actually I think it is embedding historic racism in ways that we had not expected. Now we have a couple of people who are joining us online. I think I will stop here. They're going to talk about the experience of Blackness in Dundee. Please listen with curiosity and assume that they might say something that you've not heard before. They are brave, they're medical students. That they also have no obligation to only tell us good stories. Please consider how we can practice differently and lead what we do differently. And my part of the talk really is, I really would like to oppose the use of race as a proxy for biology or genetics in clinical evaluation and management research. If you can't define groups consistently, this is Science 101, you can't make scientific generalizations about them. This is a book, actually a really good book that Dave Connell shared with me. I read it. It's really, really good. If you're still wondering about why there is not a racial basis to race, it's by a geneticist who practices in London, and it's really very good for a medical audience. And just for us to remember, first of all, we're not to do any harm. Social structures can inform our science, but exported biases have very specific history. Social determinants of health matter a lot. Algorithmic care, we should think about, and we should also think about what institutional competency looks like. What a competent, and that's kind of the part where Evie is around things like Athena Swan are about institutional competency around things like this. So I'll move on so that our students come and talk to us next.
And how do you follow that? That was exceptional. Thank you so much, Dr. Mooka, for sharing your experiences, your wisdom, and your knowledge. My name's Abigail. I'm a fourth year medical student. Maybe brave is you can argue about that later. But I have the privilege, along with some of my colleagues, to really discuss our experiences of being Black students in the University of Dundee. These are our stories. These are real stories, and we hope that you can hear them and hear the sentiment behind them. Again, like Dr. Mooka said so expertly, not everybody is a racist, but we're trying to tackle problems. We're not just problem-oriented, we're solution-oriented as well. So without further ado, I'd like to invite my online colleague, Suleika, who's going to share a few words about her experiences.
Hello, can everyone hear and see me okay?
Please.
Right, that's max volume. Give it another go.
Hello, can everyone?
That's great. Yeah, somewhere in between maybe.
Hi.
Okay, I think we're probably about there.
Okay. First, I just wanted to thank Dr. Mooka as well for that exceptional talk we just had, and thanks Abby for introducing me. So my name is Suleika. I am a final year medical student here at Dundee, and I'm just going to briefly talk about my experience that I've had with the patients so far during my clinical years. Well, I was thinking about what I'd like to share, and unfortunately, I had so many examples to think of. But one example that I'm going to bring to light was actually something I encountered as working as a healthcare assistant. And so I was a span 2 healthcare assistant, and most of my job just entailed helping the nurses and helping the patients with day-to-day tasks. And I was on the medicine for the elderly ward, and I saw an elderly patient who was unsteady on his feet, and he required help because he was a falls risk, so he required help just walking him to the toilet. So without any prompt, I saw a patient from the end of the bay struggling to get up. So I just went over to him and said, "Oh, do you need any help? I can help you walk to where you need to go." And he just turned around and said, "Oh, well, I wasn't expecting someone Black." And that comment really took me aback because it just wasn't what I was expecting. I had the intention to help. That was something I was employed to do. It's something that I wanted to do. Like no one told me to. No one assigned this patient to me. I just saw he was struggling, and I went over to help. But that comment really set me in my tracks, and I was like, I don't know what to respond to. I don't know how to respond to that. So I think when we're talking about the interactions and the lived experiences we have as students, even as employees, not a lot of people realize even the small comments that we get practically on a day-to-day basis really do affect us. And when I shared this with the colleagues that I was working with at the time, I got questioned as well, as if what I went through wasn't that serious. My colleagues were saying stuff like, "Oh, well, it wasn't that bad. He didn't actually say anything that was racist or mean. He didn't really it wasn't really that serious. He just wasn't expecting to see you." But I think the reason why I bring this up is I was still singled out. I was still made to feel like I wasn't supposed to do that. It wasn't my role. I wasn't allowed to help him because he just didn't want me. He didn't want to have someone who was a different race, different color. I can't speak to the mind of the patient and what he was expecting, but I know he wasn't expecting me. So just thinking about the comments that we get day to day, it might not inherently be racist or cruel or mean, but the comments that single us out as different is still really important. And the lack of support that I got from the colleagues as well that I was working with was really disheartening. And that's just my brief story about how the experiences that I've had as a student, and that could bring to light some of the solutions we can bring forward about being more supportive to your fellow colleagues about interactions they've had with patients, other comments that they get on that are not fair or don't seem right. And yeah, that was just my experience. I'll bring it back to Abby now to introduce the next student, but thank you so much for just having a listen.
Thank you so much, Zuleika, for sharing that experience. These are never easy things to go through. And it's great that we're able to discuss this openly and see how we can learn from these sort of experiences. I'd like to now invite up another colleague of mine, Aisling, who's going to also share a few words about her own experiences as well. Let's give a round of applause to Aisling as she comes in.
Hi, I'm Ashlyn. I'm one of the fourth year medical students. I was going to talk about kind of my interactions with like fellow colleagues and fellow students. And from what I can think of, I think we had a session and it was just talking about kind of how names kind of hold a lot of power in the medical field, and that how some people can get mistreated just because of the kind of name that they have. So I think I was the only Black person there, but obviously I don't have a very Black name. So I don't really experience it that well. But I was just interested to hear kind of like what my other colleagues had to say about it. And a lot of them kind of disagreed that when you have kind of like a ethnic name, that it affects how you can practice like as a doctor or just even as any other profession. And I think for me, it got me like quite hurt and angry because I know in terms of like my mom, she kind of went through that as well just because of her name, but it doesn't, and she's kind of gone through things where it's like they kind of question her ability to do her job. And even the practice scenario that they gave, it was very clear that it was just because of his name, the patient didn't want the doctor to treat him. So at the end of that, it just made me think that I don't think students are racist or like my fellow colleagues are racist, but I do think there can be a bit of ignorance when it comes to things like this. And I think it's just that kind of conversation to help them, like help everyone realize that it doesn't matter if you're not the one that's saying something racist, but ignorance can also play a part as well, because it does hurt kind of all of us when it's, we don't really have the backup of our colleagues or our peers or anything like that.
Yeah. Thank you so much, Aisling, for sharing that. Yeah, I think tying into again what we heard earlier, I think there's an understanding of what racism is. There's the overt racism when we see things, people say things and have an outward behavior that we can all agree is inappropriate, but these covert things can be just as damaging and just as frustrating. And just to follow on, telling a few stories of my own experience and kind of about what it means to be in a learning environment as a student. One from very, very early in my medical school career, and then one kind of happened just yesterday. So there was a time when I was in my earlier years, going to keep this as anonymous as I possibly can, where I was in a lecture theatre, and the lecturer was handing out the microphone to answer questions that were on the screen. And the dreaded thing happens if you're a student, you know that you hate this, the microphone lands in your hand and you're like, oh my gosh, I need to answer this question. Thankfully, I answered the question correctly, and the lecturer looked at me and he asked me, so what's your name? I told him my name's Abigail. He said, okay, so where are you from? And I think all of us can appreciate that's a bit of a loaded question when you're not white in a predominantly white environment. So I said, I grew up in a place called Dumfries. And he said, oh, really? Okay. But where are you actually from? And I said, okay, so I'm from a place called Ghana. And to my surprise, he was like, oh yeah, I know Ghana. I know Accra. It's the capital of Ghana. And I was kind of, taken aback, and I was surprised, like, wow, I thought this was going to be an interaction that was kind of seeded with a bit of ignorance, but wow, somebody knows a bit about where I'm from. The next question this person then asked was, do you eat bushmeat? And I was like, wait, what? And the reaction was kind of similar to what the reaction is just here, a bit of bewilderment, a little bit of laughter, a bit of like, whoa, what's going on? And I had a little bit of an out-of-body experience. I was like, is this real life? Did this actually just happen? I answered, no, it's not really something that we do. At this point, feeling very uncomfortable. This person moved on and asked another student a question, but that experience stuck with me because I was thinking all I did was answer a question, and I feel like there's a dissection into my own identity and maybe parts of culture as well, which is frustrating. And paralleling that with something that happened literally just yesterday, I'm on my surgical rotation, and I was in surgery and watching this laparoscopic cholecystectomy, trying my best to learn from what's going on. I was with a couple other students from a different university, and a staff member came up to me and he was talking to me and he said, "How long are your dreadlocks?" And I was like, first things first, my hair is not in dreadlocks. And I was like, kind of long-ish, I guess. And he was like, "Oh, there's this guy on Strictly Come Dancing that has really, really long dreadlocks. You should see he has really long dreadlocks." And at this point, the surgeon who's doing the surgery is able to ask these other students questions about what's going on. And I'm answering questions about some guy on Strictly Come Dancing with dreadlocks. So these experiences are just to highlight the fact that sometimes in a learning environment, when we're trying to be in a space where we're trying to further ourselves in our education, our attention can be diverted sometimes, thinking about not only learning in the environment, but also having to almost be like an apologist for Black people to people who don't understand things about Black people. And that can be frustrating because it takes away the energy that other students can use to learn and gives us another responsibility. So that's just a few of the stories that some of us have experienced. And again, this is not to point fingers or to point blame. Again, we don't want to be problem-oriented people. We want to be solution-oriented people. So we kind of wanted at this section of this afternoon, we wanted to kind of turn things around and engage with the people who are here and open the floor up and ask a very simple question. What can we do to improve? What can we do to change? Are there any things that we can point out as thinking, things that we can do to make this environment a more conducive learning environment for our students? Now I'm going to ask Dr. Farden if you could help me out with the technology.